Hi, everybody. I'm your host, Kyle, and this podcast is brought to you by the Multidisciplinary Association of Psychedelic Studies Canada, or MAPS Canada. This podcast is for educational and informational purposes only and does not constitute medical, legal, or professional advice. Additionally, I would like to mention to our audience that this subject involves discussion about death, illness, and mental health, and this could be challenging for some viewers. As I'm recording this podcast in Toronto, I'd also like to acknowledge I'm on the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to a diverse First Nations, Inuit, Métis people, and this land is covered by Treaty 13. So I'm here today with Dr. James Downar. He is a critical care and palliative physician in Ottawa. He is also professor and head of the Division of Palliative Care at the University of Ottawa, where he holds a clinical research chair in palliative and end-of-life care. So we're here today to discuss medical assistance in dying and psychedelic-assisted psychotherapy. So very briefly, can you give our audience just a brief history of MAiD in Canada, perhaps starting with the Carter decision and maybe going until today?
No problem. So in the early 2010s, there was a case brought before the BC Superior Court challenging the criminal code provisions that prevented people from asking for medical assistance in dying. This case ultimately was decided in favor of the plaintiff and striking down the provisions of the criminal code that prevented a competent adult from requesting assisted dying should they have a serious and incurable condition, be at a point where were in an advanced state of irreversible decline in capability and be experiencing intolerable suffering that could not be relieved by any means that was acceptable to them. And in that context, that decision was ultimately upheld by higher levels of the court, and this is known as the Carter decision, handed down by the Supreme Court in 2015. The response to that was that the government enacted legislation, Bill C-14, to legalize assisted dying. They added an additional provision that somebody had to have reached a point where their natural death had become reasonably foreseeable, even though that was not in the Carter decision. That provision of the law in Canada was subsequently challenged and successfully so by plaintiffs in Quebec, with the result that we now have medical assistance in dying available to individuals who meet those criteria, regardless of whether they have reached a point where their natural death is reasonably foreseeable. And essentially, we have two tracks where people with reasonably foreseeable deaths, that's about 96+% of all MAiD cases, go by one track. People whose death is not reasonably foreseeable go by a second track, sometimes known as track 2, which has additional safeguards and a longer reflection period in addition to assessments by at least one person with expertise in the condition the person has. So that second track has been available since 2021. And that currently is the state of the law in Canada. Quebec has proceeded apace with a slightly different way. They actually legalized through statute before the Carter decision, and they had came into effect, I should say, and they also were affected by the same Quebec court decision, so that it was no longer limited to people at the end of life. And more recently, Quebec has passed a modification to their law now allowing assisted dying by advance request. So people filling out very specific instructions about what situation they would consider to be unacceptable to them, that they would want it in a future state where they were not capable to request it by the current law. And there's some provisions around that I won't get into because they're fairly detailed. But that would be that's only the case for Quebec, and in the rest of Canada, it remains track 1 and track 2. So hopefully
Great.
that's a helpful summary.
Yes, that was a helpful summary. Get us established of exactly what MAiD is. So my next question would be, how frequently does demoralization or existential distress motivate a MAiD application? Is the motivation for MAiD usually due to physical pain or psychological distress associated with a terminal diagnosis or the process of dying?
Yeah, so the physical pain is sometimes the reason that people will request assisted dying, or fear of future physical pain, although it turns out to not be that common as a driver for people requesting assisted dying. Far and away, the most common reason that people are requesting assisted dying in their own words or from the data that we collect on this, and it's collected for every person that receives assisted dying, is a sort of inability to perform activities that they consider meaningful, or inability to perform activities of daily life that are required for them. So I think it's important to appreciate that humans are very relational beings, and our sense of purpose and what we do, we're relational in terms of we develop a sort of identity based on what we are for others, what we do for others, and what we do with others. One of the really difficult aspects of developing advanced illnesses for some people is that they've established an identity, a sense of self, centered around these things, and then an illness comes along and takes away their ability to do things that they find meaningful, or takes away the ability to essentially be autonomous in themselves. And that loss of autonomy, or that loss of the ability to do things that they find meaningful and enjoyable, and often that form the basis of their social network, their interactivity with others, is a deep assault on their personhood, who they are. And if it's sometimes when it happens very quickly and that there's no reasonable prospect of these things coming back, that can cause tremendous suffering, that people get to the point where essentially they feel like they just cannot get the enjoyment or the purpose or the value of life that they once did, and that they're expecting death, and that there's no reasonable anticipation of anything but this in their remaining time, that they want assisted dying. So I would say far and away that's the large majority of individuals who request assisted dying do so for that reason.
Okay, thank you. I know in some of the original legislation surrounding MAiD, they discussed a clinical term of enduring and intolerable psychological suffering, I believe, as one of the um, key guidelines for people who can request MAiD. So my next question would be, what are the best available traditional treatment options for treating end-of-life distress? And I'm going to use end-of-life distress as a bit of a catch-all for the anxiety, depression, like problems associated with dying.
Yeah, so that's kind of where assisted dying really, a lot of the core of the debate these days, right? So I'm a palliative care physician. Our field, has a fairly well established evidence base for our interventions, what we can do relatively well, what we are perhaps less successful at doing. And it's fairly clear that our effectiveness is definitely there. We are effective for relieving many types of distress, but our degree of effectiveness is not overwhelmingly large. So, for example, we're not able to relieve every form of distress in everyone. We are probably more effective for relieving physical distress, pain, for example, shortness of breath. Those are things for which we have perhaps more effective interventions. But when we turn to, types of distress like what you're describing, existential distress or psychological distress, the data is not so robust. Medications that we use for this type of distress outside of end-of-life situations they show that don't seem to be as effective, these interventions, that when someone is closer to the end of their life. There are also psychotherapies, I guess, available. And there's many types of psychotherapies available, lots of publications on this, many studies have been done. But the effectiveness of the psychotherapies that have been tested is I would say modest. You'll see, depending on the type of endpoint that you're looking at, you can see sort of moderate benefit in the short term, immediately afterwards, for some of these endpoints. But by the time you get to 3 months out from the end of the therapy, the effectiveness in the larger studies tends to disappear. And so these are, of course, also the psychotherapeutic interventions they're also only effective for people that really are willing and able to put the time in to do them. So for somebody who's got a very advanced illness, is close to death, that can be a substantial time and energy commitment that some people are just not willing or able to make. So again, the data that even where we do see effectiveness, this is often in, I would say, selected populations rather more than the general population of people who may be suffering as they approach the end of their life. So all of this is to say that we should not imagine that these interventions are completely useless. That's not what the data shows. But I think we have to be realistic and accept that the interventions themselves may have modest effectiveness. That we certainly can't promise that we can fix everything, but certainly there are some people who do benefit from the existing therapies that are in place.
Thank you. I think that speaks a little bit to the medicalization of death itself in the Western world, where it's a very difficult thing to treat somebody who's dying, and that can kind of get more into the spiritual or the philosophical. So, just a quick question about MAiD and the uptake of MAiD. So, I know MAiD was provided to over 15,000 people in 2023, which was a 15% increase from 2022 and a significant increase from the number in 2016 when it began. But why has MAiD seen such a rapid uptake year over year? And will these figures increase in the future, or do you think they've stabilized?
So it's important to understand that Canada, there's from data around the world. We have a lot of data around the world. A lot of people very interested in how many people are getting assisted dying around the world, and certainly here in Canada. The numbers, the percentage of all deaths that come through assisted dying in Canada are not they're not sort of out of keeping at all with what you see in other parts of the world. So, for example, the numbers here are lower than in parts of Europe, as a percentage. And if you look at the rate of growth in Canada, and then you look at the rate of growth in jurisdictions in Australia that have recently passed laws, the rate of growth in Australia is actually very similar to what the rate of growth has been in Canada in its early years as well. When you look at jurisdictions where the laws have been in place for some time, you tend to see sort of two trends. You'll see when things are initially legalized, you'll see a growth, obviously, in uptake. And that seemed to have plateaued for some time, in some cases, actually dropped in some jurisdictions. But then since COVID, there was also been a sort of fairly steady increase and fairly sharp increase, I should say, even in jurisdictions where MAiD was legal for decades, and had actually been plateaued for about 10 years. There was quite a sharp uptick, for example, in Belgium and the Netherlands, reflecting, a much greater interest in assisted dying. So I think, when people point to Canada's experience, I think you probably see what is a little bit of a superimposition of two things: the initial few years of growth, followed immediately by MAiD, which essentially made it one large increase over time. Um, the data has already shown that the numbers in most of Canada have plateaued since late 2022 and largely plateaued since 2022, 2023. You're certainly not seeing large growths. And in fact, the numbers that I'm most familiar with would be Ontario, where the numbers have been pretty steady and gone down and gone back up and gone down and gone back up now for the better part of 2 years. Quebec and BC, we seem to see continuing to grow, and those are the parts of the country with the highest numbers per se. But I think it's also important to recognize that the the focus on numbers maybe loses sight of the real issue here, which is that legalization of MAiD was about legalization of choice. The function of a MAiD system, if you will, is not actually that's not actually a very good way to measure it at all. So, giving people choice over all sorts of things, like, whether they want to have abortions, whether they want to have a vasectomy, whether they want to have any number of things. These are legal, these are options. But if you simply look at the number of people who get each one of these options, it tells you almost nothing about how the system is functioning. What you want to know much more, of course, is about who is getting it, why they're getting it, are the rules being followed, is this being used for the reason intended? And based on all the data that we actually have, it would seem that the degree of adherence to those parameters in Canada are extremely high. And so, I think on that basis, I think it's just important to recognize, whenever you hear somebody make a comment about the number of people getting MAiD in Canada, to put that number in context.
Great, thank you. I've seen a few articles recently in the last year talking about how MAiD is one of the leading causes of death in Canada, and I always think to myself, I mean, it's cancer and cardiovascular issues. It's not saying MAiD is the cause of death per se. So I find some of that debate and rhetoric slightly disingenuous, probably coming from the critics of MAiD. But okay, so thank you so much for those answers. I'd like to move on to some questions about psychedelic-assisted psychotherapy now. So,
Right.
what is psychedelic-assisted psychotherapy?
Well, I'll take a step back and I can talk to you about two different things. So we can talk about psychedelics in general, what psychedelic medications are in general, and then talk about psychedelic assisted psychotherapy and the use of psychedelics outside of psychedelic assisted psychotherapy. So, psychedelic medications are broadly a class of medications that are used to induce a psychedelic experience. So, the most common category that people think of are what are known as the serotonergic hallucinogens. So, these are medications that bind to a receptor called the serotonin 2A receptor. And that produce a psychedelic experience that way. And the most common would that we would know would be, for example, psilocybin from the psilocybe mushroom. There are other types of hallucinogens and other types of psychedelic medications and pathogens and tactogens. So some people may be familiar with LSD, DMT, ibogaine. And then there are medications that are dissociative anesthetics that can be used for psychedelic experience. That would be, for example, like ketamine would be another medication that sometimes gets put into this category. All of them are meant to share in common the notion of a that you take enough of this medication to experience a psychedelic event. So where, for example, there is a certain sense of ego dissolution, the boundary between the self and the universe around you is dissolved. Um, there's the notion of the sort of sensory changes and combinations and merging of the senses. So, for example, auditory sensations, music, for example, might be felt as tactile sensations, physical sensations, and vice versa. And this experience, again, there's I think many ways to describe a psychedelic experience, and I think many of your listeners may have actually had psychedelic experiences that I'm probably not capturing well with my words. I think it's hard sometimes to put into words what anybody experiencing a psychedelic events or psychedelic experience would go through. But that's largely what we're talking about. Now, or if I focus, for example, on psilocybin, which is one of the better studied uh, psychedelic medications. So again, it's a medication derived from the psilocybe mushroom, and people will take a given amount of it that is known to reliably produce this psychedelic experience. But if you're doing psychedelic assisted psychotherapy, this would be essentially psychotherapy where you have a planned, you know, program of psychotherapy that may last for weeks or longer. Um, and then there's a number of tasks that you do over the course of this psychotherapeutic course. So generally speaking, you have what are called preparatory sessions. So these are sessions where the person who would be taking the medication, who's got the symptoms, would be meeting with the therapy team or the therapist to try to develop a good trusting relationship, a therapeutic relationship, so that you feel safe and comfortable in this moment. You're prepared for what you're about to experience, so that people are introduced to what might happen and what the experience is typically like. Opportunity, obviously, to answer questions. And it's also an opportunity for a therapist to try to assess if this person they believe is somebody who would respond well to psychedelic therapy. So certainly well documented that therapists often will identify individuals where they may have a lot of concerns that this is somebody who is not going to derive benefit from a psychedelic experience and could find it very traumatizing. So people with a history of concern, what they're looking for essentially is something called ego strength, where someone has the ability to tolerate a moment where they are not necessarily feeling in full control of what's going on, that they're comfortable working with others to help them, in a moment where they don't necessarily have full control, and that they wouldn't find that anxiety provoking and traumatic, for example. Um, and somebody with histories of abuse, sometimes these medications are used to help people resolve histories of, the psychological damage of such an event. But it certainly can sometimes backfire and go the wrong way. So it's really important to have these preparatory sessions to help identify individuals who might not do well with this, but also for those, those who think would do well, to form that trusting relationship with the therapist. Then you would have the actual sessions themselves, the psychedelic sessions, which are, up to many hours in length, depending on the medication that you use, because they have different half-lives. And you may have more than one. And then during that, you're sort of the person, the therapist who's with you is sometimes called the guide, that they're helping you to sort of process what you're seeing. So they're supposed to, in a non-directional, non-judgmental way, sort of help you explore, as you're going through the experience of the psychedelic experience, perhaps reliving your event, but looking at it through different eyes, looking at it in a different way to help you process it differently. And obviously to be with you for safety and reassurance if you're in a very anxiety-provoked moment. So then after one or more of these sessions, there's follow-up sessions, what are called integrative sessions, when you're integrating the learning and the insights that you gained from the session that you participated in. So that would be that's considered quite essential to do. You have to, really sort of because many people will come back and say, I saw this in a completely different way, and I really feel differently about it now than I used to, and I'm not as upset, I'm not as traumatized, or I look at my life in a different way, and I feel a different sense of purpose, and this is wonderful. And that's really about solidifying that and making sure that you have that kind of rock, that pillar to go back to, if ever you're struggling again in the future. And the experience so far has been that this approach, this psychedelic-assisted psychotherapy, appears to be quite effective. So the degree of effectiveness is very, very high in the studies that have been published, and obviously leading to a lot of excitement that this might represent a really remarkable new therapeutic option for a broad array of conditions that have historically been, for some people quite challenging to treat. So that's psychedelic assisted psychotherapy. Um, then there's also psychedelics that are used outside of psychedelic assisted psychotherapy. So sometimes your listeners may be familiar with microdosing. So this is where people will take approximately 1/10 of a psychedelic dose of medications, and people have used many different types of psychedelic medications, but the most common described would be, I think, LSD and psilocybin, and for some people, DMT. But these are medications that you take in 1/10 that dose, so it does not produce a psychedelic experience at all. In fact, there's no session. So whereas in psychedelic assisted psychotherapy, a lot of the benefit hinges on this many hours long session that you have, a specific experience and an event. With psychedelic assist with microdosing, you're essentially like taking a medication every day, or multiple days of the week, for example. But you don't actually sit down with a therapist at any point necessarily. You don't have to necessarily process things or go through the therapy. You can actually go on and function. So many people will just take tiny slices of mushroom, for example, or medication at the beginning of the day, and then they go to work. And or they'll drive a car and go to work. I wouldn't recommend this. I'm not saying you should do this, but I'm just saying this is what people do. And they just report feeling better. So the classic description, they're just having a really good day every day. And so the question of how that happens, the mechanism of benefit is less clear. But we're starting to get some insights into it from functional MRI studies and other things about what it is that's going on inside the brain, that helps people, that might help people resolve or improve their symptoms from taking this. So it's just important to sort of describe. I hope I haven't, for more knowledgeable listeners, might be horribly offended and disappointed in my explanation. I hope they're not. I think people have written long, long books on this, and I'm sure many of your listeners have read them.
Well, thank you very much. That was very helpful, and you clarified there. So I wanted to respond to a few different things you said. I guess the first, I saw that you were involved. I don't know if you could speak on this, but I saw you were involved currently in a microdosing study on end-of-life patients. Is there any evidence currently of what would be more effective for treating end-of-life distress? Would it be microdosing or macrodosing?
So that's a great question. So first of all, yes, I have completed. I'm the primary investigator on a study of microdosing psilocybin. It's what we call a phase 2 studies. We were trying to find the dose that would be most effective. We were trying to look for, obviously, that it had an effect, of course, and we also wanted to look at safety issues as well to make sure that people wouldn't have substantial side effects. So we did identify that there was quite a encouraging results. So about 70% of the people in the study experienced a very meaningful, important difference in their symptoms. Symptom scores fell dramatically, or they just said they just really felt a lot better from being on the medication, which is great. 30% did not, which is obviously, still work to be done. But this is the kind of response level that you do see in the approaching the response levels I think that you see in the macro dosing. Um, what I would suggest is that it's hard to say that one approach is better than another. I mean, I certainly there is zero evidence to help you either way. You can't simply look at response numbers in studies like this and compare them for a couple of reasons. That you really need to do controlled studies where you compare things head to head. And ideally, what we're doing now with our microdosing is we're going on to do a placebo-controlled study where we're going to give some people this medication and some people pills that look exactly the same but don't contain the medication to see if we get different responses. Because one of the things you do tend to see a lot in the psychedelic literature has been written about is potentially quite a substantial placebo effect and expectation effect that people think it's going to work and therefore it works. So with microdosing, you can do a placebo-controlled trial quite effectively. The challenge with macrodosing and the psychedelic-assisted psychotherapy that I described previously is that it is really challenging to do a placebo-controlled trial because there's what's called functional unblinding. So for obvious reasons, the psychedelic experience is for most people one of the most remarkable and impactful experiences of their life. And so, if you take that and you have that experience for 6 hours versus someone who takes a placebo, unlikely that you're going to, it's unlikely you're going to get to the end of that and wonder which group you were in. Most people pretty quickly figure out that they were in the treatment group or not in the treatment group. And so it's what's called functional unblinding, that the participants now know which group they were in, and thus expectation and placebo effect come to the fore. And it's hard to tease that out. So for many of your listeners may be familiar that there was a large study of MDMA done for post-traumatic stress disorder. And it did show quite a strong result, but ultimately the FDA in the U.S. Declined to approve MDMA for this indication because they felt that there were methodological problems with the study, the most important one being functional unblinding. So it's hard to know how they're going to actually get around that, or if it's even possible to do so. There are some thoughts, but I mean, one of the advantages of a microdosing type approach is that we can use placebo trials. So we're not going to fall into, I think, the same methodological challenges of the macrodosing studies. But I would say that the other thing is I wouldn't think of them as necessarily being competitive approaches. I think that with microdosing, I can give you a pill that you can take literally the minute you receive it, and you could expect to feel benefit very quickly from it, and over an ongoing period of time. You do not have a psychedelic experience, which can be quite challenging for some people. And if you have an advanced illness, if you're very weak or frail, for example, or this could be quite a concerning thing where you wouldn't want to do a macrodosing treatment course, but because of the time involved in the preparatory sessions and everything else, or just frankly a challenge accessing therapists, it may be unfeasible for you to consider psychedelic-assisted psychotherapy, but microdosing might be really effective for you. On the flip side, if you maybe are somebody who's expected to have a long, long time left in front of you, a long time to live, it might seem more attractive to do a one-time treatment, with some preparation rather than have to keep taking the pill on an ongoing basis. We don't know a lot about long-term effects of these medications, even in small doses. And it's certainly possible to start with a microdose, for example. And if you don't experience benefit, try a macrodose if the time frame suits you. So I would really, as much as it may be attractive to sort of, have in our minds sort of battle between microdosing and macrodosing, I think as somebody who treats people at or near the end of life or people with advanced and incurable illness, I can see very distinct populations for which only one of those two things would even be on the table. And I even when both are on the table, I can very much see the wisdom in a sort of staged approach where you try one first and then only go on to the second if the first doesn't work.
Great, thank you. Yeah, you can view them as kind of complementary, or well, it's not necessarily one size fits all. It depends a lot on the different circumstances or individuals involved. But one other thing was, why does psychedelic assisted psychotherapy work so well on this population, meaning people that are very at the end of life?
Yeah, well, the studies actually do suggest that people there was a meta-analysis of studies looking at people with mood disorders and severe mood symptoms, and found that when the mood symptoms were linked to an advanced incurable illness, that was associated with a larger effect size. So you're right. It's possible that this might actually be more effective for individuals in that situation. But I'd say we don't have a ton of data yet on that. Even the pooled data is a relatively small pools. I wouldn't get too far down the rabbit hole of trying to interpret that. What I would say is existential distress, as it were, is not unique to end of life. There are actually quite predictable points in people's lives where you would expect someone to experience existential distress, where you start to question your purpose and why you're on this planet. What is, and that will commonly come, for example, as adolescence, reaching adulthood, where you sort of full of energy and ideas and enthusiasm, but limited means, frankly, and not being allowed to do things. When you, for example, are losing, a long time job, loss of a job, or loss of a life partner, either through divorce or widowhood, that's a big issue. And of course, at the diagnosis of a terminal illness, these are all really well identified reflection points in life where people start to ask reasonably questions about what on earth is the purpose now of my being here, where something that I've valued and done my whole life is now denied to me. Something that I had my whole life I no longer have. um, so it's that sort of, in many aspects you're dealing with the loss and the loss of meaning that comes with the loss. So again, I think that it's there's a spiritual angle to this that I think many people speak to, but the bottom line is that there are some people who go through these experiences and they just can't shake it. It's just really deep and troubling and burdensome suffering to them that they just can't get over, while others, they tend to kind of shrug it off fairly quickly. And to me, as a researcher, as a palliative care provider, I find that a fascinating question. Why is it? Why do some people just seem to struggle so much more than others? And I don't think we know perfectly the answer to that question. But there is, with the use of what functional MRI technology and imaging technology, we have come to a much better understanding about how lots of psychopathology gets sort of cemented into place in the human brain. So there are these kind of networks that are always circuits that are always kind of firing in the brain, and they don't all fire, maximally at once. Depending on what you're doing, one network might sort of predominate and take over, while the others are sort of silenced a little bit. And then when you go back to stop doing your task or focusing on certain things, then you go back to another network kind of taking over. And one of the common threads in a lot of psychopathology seems to be what's called the default mode network, which many of your listeners may have heard of. And when the default mode network seems to be a little overactive, of course, when one network is overactive, others are kind of pushed down. And the brain often has very good established mechanisms for switching, from one mode into another. But if the default mode kind of gets a little too strong, you can't really get out of it. And when you're in the default mode, the studies tend to suggest that pain scores will go up. So the same experiences, like the same physical injury or mass, for example, will be more painful when the default mode is more active, and that you're sort of less able to appreciate joy in things. The same item will bring you less joy when the default mode network is a little overactive. So and again, I'm sure there are functional neurologists and neuroscientists out there tearing their hair out at the simplicity of my explanation. But I try to think of it as, if you're stuck in this rut, this rumination rut, that you just can't seem to shake it. So one of the things that seems to happen is that there's things that drive us. So parts of the hippocampus that are involved in memory and anticipatory memory. So the concepts of what might happen, or catastrophizing about what will happen, and that this drives this rumination on that enhances the negative. when they've done functional MRI studies on people who have taken macro doses of psilocybin, that this connectivity between the catastrophizing and the negative experiences seems to be uncoupled a little bit. So you no longer perhaps get that driving of the negative thoughts, that you're sort of able to get out of this rut, out of this rumination cycle. And when you talk to people, um, when we spoke to our patients in the microdosing study, they all kind of told a story that was really, really consistent with that idea. Like they will tell you, well, I still get the negative thoughts, but they're not so bad, and I can think about other things. Like I don't dwell on them as much as I used to. I can move on, and I can look forward to stuff like getting my nails done or doing some gardening or just spending some time with the family. I look forward to going to work. Um, you know, Things like that. And so to me, I think it's always, as a scientific, I like to think of myself as a science focused person. It's always helpful when you can have a physical explanation, something I can look at that's consistent. I know there are people who find that perhaps a bit materialist or reductionist. Um, and people of more of a spiritual bent, that they would feel strongly that this should be viewed differently. And I have a lot of respect for that perspective. And I don't think that necessarily that I'm not necessarily going to tell you that taking this pill will change these circuits and that will change how you feel spiritually. Versus, does this pill lead to a spiritual change that is reflected in slightly different signaling in the circuits? I'm perfectly willing to concede that the mechanism of action may be a spiritual healing that is manifested in these changes in the MRI, rather than the reverse. It's just not a not an argument I want to get into.
Save that for the philosophers, maybe.
The philosophers have been wrestling with these questions forever too. I mean, existential distress, nihilistic tendencies, these thoughts. So all of this stuff was well established in the philosophical discourse around. Many philosophers wrote tons and tons on this before there was ever even a field of psychiatry, or neurology to talk about why this might be happening. So, I think, yeah, good to be humble.
Hey, we hope you're enjoying the podcast so far. Now, if you want to support and become part of the psychedelic movement, feel free to donate to MAPS Canada at the link in the description below. Thank you for helping our mission to support equitable access to legal and regulated psychedelic medicines for all Canadians.
Okay, so I'm going to move on to some questions now that kind of incorporate both two subjects while we still have a bit of time. So, how can Canadians legally access psychedelic-assisted psychotherapy, particularly Canadians who qualify for MAiD? And sort of as a side to this is the special access program an appropriate mechanism to authorize legal access?
The special access program is the legal means by which Canadians can access, macro doses of psilocybin as part of psychedelic assisted psychotherapy. Um, it is the only legal means by which you can do so, although of course there are many non-legal means by which you can access, online or in stores. I generally would advise people not to go to those sources, simply because you don't really know what you're getting. There could be all sorts of impurities, and you know I just think that although many people will use it, it will access it by that means. It's just not as reliable, I would say, or necessarily the same degree of safety as a substance that you would obtain from a licensed producer. When they produce it, the pills are in mushroom form. Even the substance, the psilocybin that comes in pills, for example, is derived from the mushrooms. They're getting it from the natural source. It's just they're measuring it in a much more precise way. So you would go through a provider, a prescriber who would be presumably somebody who's undergone training to administer the psychotherapy that is given that I described earlier. And they can complete a form. There's an actual form that you complete to get permission to get approval from the special access program that you can be dispensed a dose of psilocybin as part of the therapy. The form itself includes the program needs to know a little bit about your story, enough for the program to decide that you are somebody who could benefit from this based on what we know from published literature, and of course that you're getting it from a provider that is known to Health Canada to be a safe provider of the substance. And then presumably there may be a fee involved in that, although some places they don't charge a fee or they waive the fee. I'm not going to get into the cost of this, but it's not terribly expensive as a rule. The therapist time may be expensive, and that's something that obviously you need to discuss because it may or may not be covered by under the provincial health authorities of the province where you happen to reside. But that's how you would access it. And there are many, I think for anybody with advanced illness or somebody where you're looking to access this. If you're connected to a hospital, particularly cancer centers, many of these will have psychedelic-assisted psychotherapy programs or providers who are doing this now. And I would encourage you, if you are looking for information on it, they may have some information on their website, so you can talk to your doctor about that. Because it is, unfortunately, it is a bit piecemeal. So there's no standard approach to this across the country, but finding a provider would probably be best started there. And so that's probably the way to do this. I think that some people find it frustrating that you have to fill out this form and go through this whole process. I do push back on that. I am a defender of Health Canada. I'm a defender of the Special Access Program, and of course the notion of controlled substances, because it is very easy to fall into the trap of believing that because somebody has an incurable condition, that this is a sort of should be a situation where sort of all bets are off and we can try anything. You can cause a lot of harm to people that way, and I think we have to. I mean, you can conduct research in different ways in this context, but I think you still have to maintain the scientific rigor around these questions rather than just sort of simplistically say, what do you have to lose? Just try anything. Anything that anyone's ever said is beneficial. I think we have enough data on psilocybin to know that it's not in that category. It's definitely something where clearly there's something going on there, and it's definitely offering a lot of benefits to a lot of people. I think that and if we stick to the process, like we do need to know more about safety. We do need to know about what happens, sort of long-term exposures for those people who are not sort of imminently at end of life. And as we do that type of research, as we get more studies under our belt, this becomes the mechanism by which we can look to change the status of the substance, so that maybe perhaps it's no longer a restricted substance, perhaps it becomes just a controlled substance, or perhaps it becomes something that you can prescribe quite easily without lots of additional safeguards. This brings the cost down, this brings the accessibility up, and that's the process through which we must go, because there are, again, you're taking substances, and somebody with lots of with advanced medical problems, you can harm people with these things. And I think I do appreciate the rigor that Health Canada applies to this question. Somebody when you're a person suffering, when you're a family member of somebody who's suffering, this seems like a desperate circumstance, and it may seem very heartless for people to do things that might seem like putting up barriers to your accessing of something that may be of benefit. But someone's got to take the dispassionate approach. We all have compassion. We know that we want these people to feel better, but the need to do something cannot be turned into the need to do anything. We will get. I have every confidence that with good, rigorous studies, that we'll get there. We're gonna, we'll figure out the optimal dosing regimen, the right type of psychotherapies to administer along with it. But we're only going to be able to do that if we're doing the research properly.
Great. Thank you. That was a very thoughtful answer, and I appreciate it. So my next question is potentially a little bit sensational. So the sentence "mushrooms before MAiD" has appeared as a title in a few recent articles that I've read. So lawyers in the Lance court case in 2023 made assertions that a person suffering from cluster headaches would have easier access to MAiD than they would legally accessing psilocybin as a treatment option. So there's kind of been some implications of people saying it's easier to access MAiD than mushrooms. Would you say, is that true?
Well, I can tell you practically that that's not true at all. I went to lunch the other day with a colleague, and on our way to lunch passed 3 dispensaries. So I can tell you that I could not have gotten MAiD on my way to lunch, I could have gotten enough mushrooms to, well, let's just say to float a school bus. But the issue here is a false dichotomy. Okay. This is not like MAiD should be easy to access for people who are eligible. There's no question. Like putting artificial barriers in place or making it just generally difficult to access MAiD is not a safeguard, right? That's just an irritation, right? Like you don't sort of reduce the impact of one inconvenience by adding inconveniences to other pathways. That said, it should also be easy for people to access other proven or plausible therapies for other things. And if the concern is that, we want to bring down some of the challenges or reduce some of the challenges that people experience to access medication, that's an argument that could be made. And I think that, in a context where, like you want to be careful, you want to be mindful of risks. And yeah, but I think your risk paradigm, your risk tolerance, you can be adjusted in a context where MAiD is a legal option, right? So again, you don't want to be handing out potentially dangerous medication, really easily to everybody. But that said, when MAiD is a legal option for somebody with cluster headaches, if we believe that it is, and it would be a track 2 case. You're looking at many months of assessments, etc. So I'm sorry, if someone's telling you it's easier to get MAiD for cluster headaches than it is to get mushrooms, that's just wrong. But the point being that it might be actually challenging for you to get mushrooms. It can be challenging for you to get mushrooms to help try this. Again, what the evidence base is for the use of psychedelics to treat cluster headaches, I'm going to have to beg ignorance here because I'm not familiar with that literature. So, but I think, and if there isn't that literature, that's a spur, or should be a spur for the research community to get the move on, right, and start to do this. And I think that if there is one thing where clinical trials in Canada, we could make it a little easier to do some of these trials. So, for example, when we embarked on our clinical trial for microdosing psilocybin, it took us 4 years from the minute we got the funding decision to enroll our first patient. I had to spend, more than $10,000 constructing security in my office to store the stuff. It's quite a process to go through. And if there were more resources available to help investigators through that, if it was, the licensing, for example, around restricted substances only applies to the principal investigator. So, for example, if I can't give the medication to a study nurse, for example, to distribute on my behalf. I can't give it to a pharmacist to give to patients as part of the study on my behalf. It has to come straight from me. So that's a bit of a limitation. So I could see that, if you've got pharmacies with lots of security where, you're handling other types of potentially very dangerous substances, very high potency opioids, etc. It's not obvious to me why that could also, you could simply apply the same regulations to psilocybin that you apply to those medications, particularly considering the fact that I passed 3 of them on my way to lunch. Like that you can just go and buy them, or you can order them online. And I think we just have to start to be a little bit more mindful of adjusting our risk tolerance and some of our safety parameters when assisted dying is a legal option. So I think that's a fair comment, but I think it's a bit sensationalistic and factually untrue to say that it's easier to get MAiD than mushrooms.
Is there any information on psychedelic-assisted psychotherapy in the MAiD curriculum? So if the average person is approaching their physician or a nurse practitioner and they have a request for MAiD, they have interest in MAiD, does the average doctor in Canada, are they aware of the option?
There isn't a standard list of things that are offered to every person requesting MAiD. And I think there's obvious reasons for that. It doesn't, you can't list all the potential options. I think that any proven effective therapies people should be aware of. And again, something can be effective without being highly effective. So, it's not correct if somebody hasn't tried literally everything on the list. It's not correct to sort of say, oh, they gave up or this was preventable. That's, there's, for many of these therapies, you may see actually the majority of people who take them don't experience any benefit at all. So, but they should have an access. They should have reasonable access to them. I would say at this point, given the evidence, if somebody is experiencing psychological distress that is very, existential in nature, and that there may be an opportunity, time-wise, to access psychedelic-assisted psychotherapy, macrodosing, because microdosing is not available through the special access program because there isn't enough published data yet. We're working on that, guys. We're trying to get the paper published, and it may become an option available at that point. But I don't work for Health Canada. I can't make that decision. But again, I think it would be a reasonable expectation that anybody considering any therapy at all, MAiD or otherwise, is being presented with, whatever any other person with that physician's training and background would be expected to be aware of and offer. So if with the data being what it is around psychedelic-assisted psychotherapy, I think people should be prepared to at least be knowledgeable about it. That somebody considering MAiD should be made aware of something like that as another option. Not they may or may not take it, and they certainly are under no obligation to try it. But they should be aware that it exists and that a lot of people find it quite helpful. And I think that's a very reasonable suggestion. The problems, I mean, these aren't things you can write into legislation. You can't, because again, the evidence evolves around this constantly, and we may discover later that there's some challenge. Also, understanding that the people who are doing this are people who want to do this, right? So you want to be careful not to imply that this is the standard of care, that everyone should get mushrooms before they get MAiD, because many people wouldn't want to try mushrooms and they wouldn't want to go through weeks of therapy. So we have to be careful to make sure that these are options, these things are realistically accessible and offered, but not to imply that they're obligatory or that a failure to offer and provide is a lapse in care.
So you mentioned the track 1 and track 2, track 1 being death reasonably foreseeable, track 2 being death not reasonably foreseeable. So for the track 2 cases where death is not reasonably foreseeable, the criminal code section 240.2 requires that the person be informed of all available and appropriate means to relieve their suffering. So does this create a legal duty to inform people seeking track 2 MAiD of psychedelic-assisted psychotherapy as an option? Are all available treatment options being exhausted if they don't try that?
Reasonable and available would be a sort of key point here, right? So, what a medical standard would be in the standard of care, which is there are different ways to define standards of care. Those may relate to explicit guidelines or expert opinion. I don't know if we can say we're at a point where in Canada or anywhere in the world, I should say, where psychedelic assisted psychotherapies are the standard of care. That's a pretty high bar, meaning that if you don't offer it, because again, let's take a step back. The vast majority of people who experience severe existential distress are not asking for MAiD. The study suggests that severe existential distress is probably experienced by 35% of the population before they die. MAiD's ticking up to 4%. This is, again, like that's maybe 1 in 10 are asking about MAiDs. So, if you're going to say that it's standard of care for people asking for MAiD, why would it not be standard of care for people not asking for MAiD? Is it only a problem? Are we prepared to tolerate existential distress and severe suffering in people who aren't asking for MAiD? Then it's fine. But the minute they ask for MAiD, all of a sudden we're trying to arrest doctors. I would say that's a problem for me. Like I think that we are probably close to having some fairly good data, and this would be an approved indication, right? This would be that once it becomes an approved indication, then it can advance to standard of care. But I think we do need a little bit more data around safety. So that's particularly for track 2, because, once it works, understanding that it also could make people actually worse. That's definitely been documented. People have gotten PTSD from their psilocybin. I think that if you're going to say something's the standard of care, you need a deeper, broader, and more universally convincing evidence pool than we've accumulated to date. And I'm not saying it's not going to come, because we are still early on this, despite the fact that they've been around for decades. We just I as somebody who works in this field, we have to be careful not to grant this and sort of start immediately jumping onto promising therapies, making them approved, cutting corners in the approval process, and then saying this is standard of care and that it must be offered to and provided to everybody, or else, if there are professional consequences.
Do you think that the widespread implementation of psychedelic-assisted psychotherapy, where appropriate, could reduce the prevalence of some MAiD cases?
When we get to the point as a country, as a regulatory body, that we can wrap our heads around some of the methodological limitations of studying psychedelic-assisted psychotherapy, and are we willing to just accept that and say that there are limitations, obviously, but we are prepared to go forward and allow this, approve this, for specific indications, on the understanding that we're going to be continuing to collect data around the practice, so that we can understand the longer term health effects or what happens to these individuals. I think that that's the next logical step in what we're doing now, simply because I think, with the functional unblinding and other towns, I don't think these are obstacles that can be overcome methodologically by a researcher. I think we just have to accept that they're there. In terms of people avoiding MAiD requests, well, I think there are even now certain MAiD requests, that when somebody gets into the system and they request MAiD assessors will say, oh, you know what, you haven't seen this type of specialist yet, or are you aware that, what if I connect you with those resources? And there's definitely, and it's well documented, certain individuals that they actually access the services they needed as a result of the MAiD assessment process. So I think it's already the case that that therapies like this are changing, that a person makes a MAiD request and ultimately decides not to go ahead with it because they access the service through the MAiD process. I think in general, it'd be nicer if that same process was available to people to get connected with services before they ask for MAiD. Again, following on the previous comments, but that's true. And I think that if we, the data from what we understand about existential distress and the role it plays in MAiD requests and the potential mechanism by which psilocybin works, I think it's very reasonable to believe that there are cases of people who might get better, who might have their distress improved as a result of going through this. I don't think there's enough data yet to just say how often that might happen, or whether it happens more. Because also there are a lot of people who request MAiD, they are found eligible for MAiD, and they ultimately don't go forward with it. So it's already the case that some people who request assisted dying and are found eligible for it, they ultimately just the fact of knowing that it's there for them as an option, they feel relieved enough by that, they find the knowledge comfortable enough that they won't go ahead with assisted dying. So you always have to do these comparisons and to sort of say, did I avoid a MAiD procedure by giving somebody psychedelic-assisted therapy, or is that something that is likely to would have happened anyway? Is it within the same rates? In which case we can't necessarily credit the psilocybin with doing that.
Thank you, Dr. James Downar, so much for volunteering your time, joining our podcast, and all the great work you do.
I really appreciate a chance to go through this, and I think you and your listeners obviously are really, quite familiar with the ins and outs of psilocybin in Canada and how it's regulated. I think there's a really exciting future here. I think that we're probably only scratching the surface of what roles psychedelic medications can play, and this class of medications might play at whatever dose, macro or micro, in a variety of different conditions. And MAiD may be part of that, but it will be at most a very small part of that.
Thank you, and I'll see you next time.